Okay. Good afternoon and good evening to everyone. Thank you so much for joining the Girls Flow Free webinar. Today we will be talking about perimenstrual syndrome, and Dr. Osei will be our presenter for the day. I will allow Dr. Osei to introduce himself and then to go into the presentation. Dr. Osei, I'm going to give it off to you. Thank you.
Okay, thank you very much. My name is Dr. Osei Asibey Owusu. Sorry about that. I'm a medical doctor currently undertaking a PhD in clinical cardiovascular frailty in the UK. But I was a resident in OBGY, obstetrics and gynecology, whilst practicing in Ghana. I'm also part of the Girls Flu team, and this is my second time coming here to speak to you about health conditions, which I feel and I believe have become a very big challenge to us to us Africans in diaspora. And today I will be speaking on sorry, premenstrual syndrome and I will specifically emphasize on a disease condition which I think is very important called endometriosis. So thank you very much for having time and having me here. Hello, Linda.
No problem. You can go into your presentation.
Okay. So today I'm speaking on two main topics. I mostly don't see them as different, but it's very important that we know about them and how they mostly affect our individual health. So I'm speaking about something called premenstrual syndrome, called PMS, and the second one is endometriosis. Now, together with these two, we call them the perimenstrual syndrome. Perimenstrual syndrome means that disease condition or symptoms that affect people before menses and sometimes continues through menses to even time after menses. So my table of content will look at a very short overview of what premenstrual symptoms are. Then we'll go into details on endometriosis. We'll look at the etiology of endometriosis, sites of endometriosis, and to conclusion. So when we say PMS, sorry, I'm having a very bad cold now. When we say PMS, we are looking at symptoms that affect women's or women can experience in the weeks before their period. And it's very, very important because these things can really affect the way of life of that particular woman and their experience with menses, even going through menses until the time they are done with menses. And it can affect anyone who has the capacity of having their periods. So some common symptoms of premenstrual symptoms are mood swings, feeling very depressed or irritable, feeling upset, sometimes anxious or emotional. Some of them comes with a lot of tiredness or trouble sleeping. Others have bloating or cramping. And in some severe cases, they have very, very severe lower abdominal pains. And some of them have breast tenderness, headaches, spotty skin, greasy hair, and changes in the appetite or food cravings. Now, when you have these things, sometimes can affect, as I said, your way of life, how you carry on with your day-to-day activities. But there are some things you can do to help and something that you don't need to do. Now, the common things that can be done to reduce these symptoms are regular exercises, eating very healthy and mostly a balanced diet, refraining from very some of these fizzy drinks or very, very sugar drinks, and eating very, very healthily is very important. Sometimes ensuring that you have such a balanced diet, getting plenty of sleep, trying to reduce stress, by doing other things that can help reduce stress, like yoga, meditation, and all that. And in some severe cases, you can take ibuprofen or paracetamol to reduce the pain that you go through, and keep a diary of your symptoms for at least 2 menstrual cycles, so that it gives you an idea of some of the symptoms that you may be having. And if you have to go to the GP, you can easily explain it in good details for them. And some of the things that you don't have to do is smoking or taking alcohol during this period, because smoking, alcohol, and some fizzy drinks have been known to make these experiences very severe, or make the premenstrual syndrome very severe during the period of time. Now, when it comes to that, what can you do to manage it? In most situations, when you go to your GP or when you go to your doctor, they may observe you and may encourage you to undertake some of the do's that I mentioned about to reduce the experience. But in severe cases, some of them will put you on combined oral contraceptive pills, or they will refer you to see a cognitive behavior therapist. And in a very severe case, some of them will be put on antidepressants. Acupuncture can help, sometimes reflexology, and taking some vitamin supplements such as B6, calcium, vitamin D, and magnesium sometimes helps. So basically, that is what it is when it comes to premenstrual premenstrual syndrome. Now, one of the symptoms of premenstrual syndrome is severe lower abdomen or menstrual pain. And that is where I want to put a lot of emphasis for our discussion today. Because one of the conditions which has been known to precipitate or cause a lot of lower abdominal pain during this period of time is what we call endometriosis. And it's something that is mostly missed. It's a diagnosis that is mostly missed. And I want to also take my time and take us through so that we are aware of what they are. So what is endometriosis? So endometriosis is the presence of a functional endometrial tissue outside the uterine cavity. So what happens is that when you have an endometrial tissue outside the body, so it can be on the ovaries, it can be on the bowels, tissue linings within the pelvis, and this tissue behaves like the endometrial lining and bleeds during your menstrual cycle, you will experience what we call endometriosis. It's one of the commonest benign gynecological conditions, as in, if you look at the incident rates, almost every 21% of women with infertility present with endometriosis. 15% of women who present with chronic abdominal pain present with endometriosis, and 6% of women undergoing sterilization, so who have decided to maybe stop having kids and they are undergoing sterilization, 6 of them is as a result of endometriosis. Now, if you look at the diagram I have here, I don't know whether you can see that my cursor. Can everybody see my cursor?
I can see it.
Yeah. When we say the endometrial lining, it is where my cursor, the space my cursor is showing, that lines the endometrial cavity, or what we call the uterine cavity. That is the endometrial lining. Now, it is within this endometrial lining that has the capacity to undergo what we call undergo a lot of cyclical changes, be filled with blood to support pregnancy in case there is pregnancy within your menstrual cycle. But when there is no pregnancy within your menstrual cycle, these endometrial linings shed the blood, and the blood comes out in a process called menstruation. Now, it's only in the uterus that we have this endometrial lining, so it has the capacity to bleed. But in endometriosis, some of these endometrial lining tissues tend to be formed outside the uterine cavity. So if you see the picture I have here, you see on the fallopian tube, you can see these red dots. These are what we call endometriotic tissues, or This is as a result of the endometriosis. You can see the ligament over here too, on top of the uterus, on top of the ovaries, and still on the fallopian tubes. They develop these endometrial tissues, and during their menses, while the uterus is bleeding, these specific tissues also start bleeding. Now, as I said, it's mostly common among women between the ages of 25 to 35, but it can occur between any period between when a woman starts getting her menses until when their menses completely stops. So between menarche and menopause. Now, how do they form? There are about 6 theories that have been postulated to tell how your endometrial tissue can be found outside the uterus and be found in any other part of your body. So the first one is what we call the implantation tissue. I will just explain it, take my time not to bother you with a lot of big words, but try and explain it because it sometimes gives you, you yourself, if you have it, you can easily identify why probably you had it. So we have what we call the implantation theory. We have the coelomic metaplasia theory. We have the induction theory, the metastatic theory, hormonal influence theory, and the immunological theory. Now, the common one is what we call the implantation theory. So the implantation theory explains that the endometriosis is caused by implantation of endometrial cells by transtubal retrograde menstruation. So what does that mean? So during your menses, instead of the menstrual tissue coming through the uterus, through the cervix, and through the vaginum out, they tend to push into the fallopian tubes. So that's what we call the retrograde implantation. It goes through the fallopian. Some of them are able to go through the fallopian tubes, through them and some of them spill into the peritoneal cavity or into the abdominal cavity. So then the cells can be implanted on the ovaries. It can be implanted on the back of the uterus, around the uterus, and sometimes in the intestines. And these things can be very, very problematic when these cells become now implanted outside the uterus. Now, the second one is through scar, what we call scar endometriosis. So I know some of us have done cesarean sections, or some of us have done myomectomy, so fibroid removal. Now, in the process of doing the cesarean section or the myomectomy, some of the endometrial tissue are planted outside the uterus, outside the uterus, or sometimes along the incision marks that was made during the process of maybe removing the baby or removing the fibroid tissues. And those are what is called the implantation theory. Now, the coelomic theory is based on the fact that most of the cells within the bodies are developed from one embryonic tissue. So if you go back to our biology, some of the tissues that are formed from our body, they all stems out of one embryonic tissue. So because they stem out from one embryonic tissue, sometimes they have the capacity of changing cell type, which maybe it might be on the intestine, but may change from the cell type from the intestinal tissue, maybe to endometrial tissue. So it is a normal tissue, but something happens to it, then it takes on its what we call embryonic mesothelium and changes it into maybe an endometrial tissue, sometimes from the response of hormonal stimulations. That sometimes happens, and you find an endometrial tissue now developing outside the endometrial cavity and causing problems. We also have the induction theory. It proposes that an endogenous biochemical factor, so maybe someone takes a drug or a chemical substance, and the substance has the ability to change some cells outside the uterus, now into an endometrial tissue, so that during your menses, when you're having your menses, those tissues start also what? Bleeding. Then we have the metastatic theory. Theory explains that the pelvic endometriosis, which result from vascular or lymphatic dissemination. So the same theory that people believe that when you get cancer at one part of your body, it's able to spread to the other part of your body. The endometrial tissue too can use the same pathway, though it's in the endometrium. They can go through blood vessels, go through some lymphatic tissues, and be implanted at a different part of the body and start causing problems. Hormonal influence. Some people, because of the change in their hormonal state, mostly by estrogen, are able to trigger other tissues within the body to now start producing endometrial tissue. Same with immunological theory. Endometriosis can be caused by decreased clearance of peritoneal fluid, endometrial cells resulting from reduced natural killer cells activities or decreased macrophage activity. So during your menses, whilst you are shedding endometrial tissue, the body has the capacity to remove any other dead tissue from the body. But when that capacity of the body to remove this dead tissue doesn't happen, then these cells can be implanted in any part of your body and they start causing problems. So what are the common sites for endometriosis? Mostly you find them on the ovaries. Mostly you find them on the ovaries. The other side that you can see is what we call the cul-de-sac. The cul-de-sac is a small pouch between the uterus and the large intestines. There is a small pouch there where fluid gathers. Most of the times to these tissues or the endometric tissues can be found over there. So it's either at the back of the uterus or within that small pouch that is over there. Or it can also be planted alongside the peritoneal ligament around the bladder. The bladder, so there are two organs. I don't know whether I can see it. I don't have that diagram. I may be able to find that diagram. If I can see that, I will have shown you. So between the uterus, there are two main organs. So behind the uterus is the large intestines, and in front of the uterus is the urinary bladder, which we keep a urine. So between these two small pouches, these cells can be collected over there, and when you have your menses, they also bleed. And they can also be found, as I said, from scar endometriosis during where maybe when we were having a procedure like CS, the scar that was made on the uterus can start having endometrial tissue. Sometimes around the umbilical cord or on the umbilicus, you can also have that. And some around the cervix or episiotomy scars, you can have these endometrial tissues forming over them. Okay, so there's another picture that you can see showing you the size. So if you look at this, where my cursor here is, this is the endometriotic tissue. It looks like a blood clot. That's how it looks like. And you can find it on the body of the uterus. You can find it on the big fallopian tubes. You can find it on the ovaries too. Here is the second diagram shows many different sites. So these are the large intestines, and you can see a lot of endometriated tissues over there. So you've seen this one too on the fallopian tubes. Then even on the small intestine, sometimes you can find them implanted over there. They can be implanted on the rectum also, and that can be very, very disturbing when they get implanted over there. So let us look at how you can classify them. So there are two classifications that can be used to classify them. So either they are mild, minimal, mild, moderate, or severe, or if there is a component of infertility as part of it. So let me show you a picture of it. So the grade 1, which is the minimal, if you have just small amount of endometriotic tissues on the body of the uterus, that is where we have minimal. The mild is when they are quite bigger. You can see it just not only on the uterus, but you can see it on the ovaries and on the walls of the pelvis and on the walls of the uterus, then that is called mild. So the same thing happens with the moderate and also to the severe. All looks at the intensity or the amount of endometriotic tissue that are found there. Okay, let me skip this part and let's go straight to this diagram. So this is an actual picture of showing you how they look like on the physical body. So if you can see these lesions all over here, there's an endoscopic picture showing these lesions on the peritoneal cavity. Another ones over here, these dark red tissues found over there. These are all endometriotic tissues that are formed, and that is what we call endometriosis. This is an endoscopic, laparoscopic images directly showing you how the endometriotic tissues would look like. And one of the complications you mostly find is when they form what we call a chocolate cyst on the ovary. So there's a diagram of it. This is how it looks like. Now, because you are getting a lot of periodic menses, they start accumulating around the ovary and they start becoming very darker, and it forms something we call a chocolate cyst, a very big cyst around the ovary. When it comes to this, it requires that there's an intervention. You have to go in and drain this cyst, or sometimes remove the whole cyst. Sometimes it affects the whole ovary, that you have to take the whole ovary out just to make sure that the person is safe. Now, an ovarian cyst can be very dangerous because it can rupture, and when they ruptures, they become an emergency. So when you identify an ovarian endometrioma or ovarian cyst, which we also call the chocolate cyst, as a result of endometriosis, we need to go in, intervene, and remove them. So, what are some of the typical clinical symptoms? The reason why I added the premenstrual symptoms and the endometriosis because of their common presentation of pelvic pain or painful periods. These are the common intersection between these two, pelvic pain and painful periods. So before menses, they experience severe pelvic pain, and during menses, they experience what we call dysmenorrhea. They can also have cramps 1 or 2 weeks around menstruation. They also experience heavy menstrual bleeding or bleeding between their periods. So after their menses, sometimes a week or two after their menses, they start bleeding again because of the endometriotic tissues that are formed around the uterus or sometimes formed inside the uterus. Then one of the commonest complications they present with is infertility. So if anybody is having complications of getting pregnant, one of the things that has to be ruled out is endometriosis. And when you go to your GP or you go to see your doctor, they will try to exclude endometriosis as part of their final diagnosis. If you've been having very severe pain during sexual intercourse and you can't really account for any other reason, this could be endometriosis. It is defined as, it's called deep dyspareunia, because the pouch behind the uterus is in direct contact with the posterior end of the cervix. So anyone who is having endometriosis, mostly around that period, around that part of the uterus, when they have sex, they experience deep pain. They also have discomfort with bowel movements. They may also present with lower back pains that may occur at any time during your menstrual cycles. Other symptoms might be hematuria and hemoptysis. Hematuria is when you urinate blood. Hemoptysis is when you vomit blood. These are symptoms when the endometriotic tissues become transplanted into the lungs. So these are some of the clinical features. I've talked about dysmenorrhea, I've talked about dyspareunia, and I've talked about infertility. So dysmenorrhea is usually when there's congestive type pain related to the location, not extent of what the lesion. So as I said, when you have congestion at the cul-de-sac or the pouch of Douglas, where is behind the uterus, you experience dysmenorrhea. You can also have dyspareunia involving the cul-de-sac or the uterosacral ligament, produce adhesion or fixation of the uterus, movement of the cervixes, elicit severe pain. Now, another clinical features we've talked about is the infertility. I mentioned that involvement of the ovaries produces adhesions, blocking tubal ovarian motility, and ovums pick up, leading to what? Infertility. They can also lead to severe chronic pain, and they can also lead to endocrinological abnormalities, such as you are not able to ovulate, and the last, luteal insufficiency, luteinization, or unruptured follicles. Sometimes the follicles are so it gives you a lot of pelvic complications. And one important other complication is that when some of these tissues which are found outside the uterus, and they are located around the perineum, they are located around the large intestines and the small intestine. They can lead to adhesions because they are bleeding every month. They are sending blood into your abdomen. They are spilling blood into your abdomen, and this irritation of the abdomen can lead to adhesions, and adhesion can also lead to very, very severe conditions. And this is something of the things that we need to be careful about. So if you look at the diagram I'm showing here, these are what we call adhesions. These bands that are connecting every part of the body together because of this endometriotic tissue that are found in it. So you will find this band plenty within the abdomen, and this can lead to a lot of complications for the person who is experiencing the endometriosis. Now, how can we identify endometriosis? So there are three things that you can do under physical examination to pick up endometriosis. By doing an abdominal examination, may reveal tenderness, fixed cyst mass in the case of the chocolate cyst. And when you do speculum examination, you might reveal a bluish or blackish packed spots in the posterior fornix. So at the posterior part of the vaginum, you may see some red spot or sometimes bluish spots over there. And that can give away that when you do a perineal or vaginal examination, you may also get a retroverted uterus, or sometimes a very stony or hard nodules at the pouch of Douglas. So at the posterior part of the cervix, you might be feeling this very, very hard substance over there, and that can give up the diagnosis of endometriosis. So what can also look like endometriosis? Pelvic inflammation disease can look like endometriosis. Uterine masses can look like endometriosis. Malignant ovarian cancers can look like endometriosis. Then sometimes a ruptured chocolate cyst is just a differential diagnosis for also acute abdomen. Then chronic pelvic congestion syndrome, rectal carcinomas, all of them can present as symptoms that looks like endometriosis. So what investigations can be done? The common investigation the doctor will prescribe for you is to do an ultrasound, mostly a transvaginal ultrasound. So they put the probe through the vaginum, and they might see this cyst around the ovary, cyst around the fallopian tubes, and sometimes congestion behind the posterior fornices. But the gold standard is to do what we call laparoscopy. So the doctors will drill some small holes through the abdomen to use a camera on the tube to observe directly this endometriotic tissue. So the picture I showed to you was an example of a laparoscopic pictures taken from the laparoscopy. And sometimes they can take this tissue, investigate it, and they will find out. But they can also run this lab called CA125. And if you are having more than 35 units per mil, proportion to it can be a definitive diagnosis for endometriosis. So if you are suspecting that you're having endometriosis, first an ultrasound can be done for you. If the suspicion is high, they might do the CA125 first to confirm. If it happens, then they will go ahead and do the gold standard and laparoscopy, because the laparoscopy can be also used as a treatment option for you. Now, what can we do? When you have endometriosis, sometimes, most of the time, the doctors will just monitor you between 6 to 8 months to see whether the symptoms will resolve. Or they will undertake some medical treatment, or the ultimate is to do a surgical intervention to stop the pain that you are going through. So in terms of medical treatment, what are the indications? If there is a mild pelvic endometriosis, not a severe one, a mild one, then they can give you medication. Or if they've done a treatment surgically and it has come back again, they will want to do a medical intervention for you to prevent it from happening again. So what are some of the medical interventions? The commonest one is the oral contraceptive pills. The oral contraceptive pills. Now, what this does is that it causes amenorrhea. It induces amenorrhea. It induces amenorrhea, which means that you are not getting your menses. Or it induces what we call a pseudo-pregnancy period, where your estrogen levels are so minimal to cause the menstrual cycle to start. Or the second part is what we call the decidualization. Instead of causing the endometrial tissue to be filled with blood and finally breaking down to produce the menses, it stopped that process. And in stopping that process, they might not be bleeding out of this endometriotic tissue. So it prevents the symptoms from happening. Now, some of the doses is 30 to 35 microgram of any estrogen therapy, a combination therapy, and you might take it between 6 to 12 months and you'll be fine. Sometimes they give you the progestins, which is the progesterone only pill. And mostly people prefer this one because of the less side effect compared to the estrogen ones. Then another drug that they can give you is what we call the danazol. The danazol are prostaglandin inhibitors or pituitary inhibitors. And when they give it to you, it prevents from the pituitary gland from producing hormones that will affect the kidney, affect the ovaries to produce this estrogen. And it sometimes works very, very well. So that one, they give you about 200 to 800 microgram for about 3 to 6 months to see if it will cause it to stop. Then they can also give you the GNR analogs. And what these ones does, that it shrinks the endometriotic tissue. It shrinks them significantly. Another drug which is in the market is letrozole, which is also an aromatase inhibitor, which is effective in the treatment of endometriosis. Now, in some cases, they may have to do a minimally invasive surgery. Minimal invasive surgery. And the goal is to excise some of the visible endometriotic lesions, to excise some of them. So in the act of them doing the laparoscopy, they can use the same device to excise some of these or burn some of these endometriotic tissue. And when they do that, it helps relieve the person from the pain. Or when you develop what we call ovarian cyst or ovarian endometrioma, they might go in and also vaporize it using a CO2 laser to destroy it. Sometimes they will have to go and remove the whole cyst. What we call ovarian cystectomy can also be done to remove it. And there's another procedure called laparoscopic adhesiolysis. So when you start developing adhesions as a result of the endometriosis, then they can go in and use the procedure laparoscopic adhesiolysis to reduce the adhesion, because sometimes the adhesions might have caused tubal blockage to restore the tubal patency. And the other one is what we call LUNA, called laparoscopy uterosacral nerve ablation. So what they do is that they go into the pelvis, try to bend the nerves that supplies the pelvic rigid so that the pain that the person is experiencing is really what reduced. They do it mostly in those who are experiencing a very extensive lower abdominal pain, but they are not ready to do a massive surgery because maybe they still want to get pregnant or anything of that sort. This procedure can be done for them. So this is what we call that adhesiolysis. So all these things you are seeing over here, all these things are adhesions. And you see, they are pointing to you which endometriotic tissue had caused these adhesions over here. So they will go there, use this laparoscopy to remove all these adhesions for you. Same situation you can you can find over here. And this is what we call the ovarian cyst. So you see this ovary, this is the ovary, and this is the ovarian cyst that I was talking about. So they will go in laparoscopically and excise this ovarian cyst from it so that you don't experience the pain that you are experiencing. Now, the definitive treatment for endometriosis is major surgeries. The uterus has to come out, or where the endometriotic tissues are has to come out. So they can do a laparotomy, open up the abdomen, go in and remove the whole uterus out, or remove the whole of the fallopian tube and the ovary that had been involved, called the salpingo-oophorectomy, or the abdomen, the whole uterus is done to remove it. Or sometimes they just do the laparotomy to go and just bend only the endometriotic tissue, and you'll be fine. And sometimes they also go ahead and do a combined therapy where they give you medication and a surgery together to help you relieve the conditions. Now, prophylactically, what can also be done? As I said, they give OCPs. Sometimes they give pain medications to help you relieve these procedures. And when you also have a classical CS or hysterectomy, they also ensure that these scars that are formed are removed and you are free from developing endometriosis. So in conclusion, endometriosis is a chronic condition that idiopathically, meaning what causes it, has yet not been determined, but we know that some of the 5 etiologies can result in producing an endometriotic tissue away from the uterus, which can cause these problems. But with the treatment available, either medication or hormonal therapy or surgery, we can use to remove or reduce the symptoms or the condition that you've been going through. Thank you very much. And I'm sorry for taking a lot of your time. I thought I could do this one in a very short period of time. Thank you very much.
No problem. Thank you so much. This was very educational. What I will suggest for those who have questions, you can feel free to formulate your questions in the chat, and I can speak them out and ask those questions. Um, I have a question, Dr. Osei. Um,
Okay.
you mentioned that endometriosis can also occur on the large intestines, on basically on the organs outside of the uterus. And
Yes.
you mentioned just most recently that one of the ways to relieve yourself of endometriosis is to remove the organ that, for example, the uterus.
Yeah.
Now, what is done in the case of endometriosis on the intestines? How do they treat that if it's not just confined to the uterus, fallopian tube, ovary? How do they treat that?
Yeah. So with that, they can do the lunar. So they use what we call laparoscopic aberration. So they go there, they use the laparoscope. The laparoscopic machine have sometimes an aberration, or what we call a heating mechanism. So they go in, they burn that endometriotic tissue. So if it's on the intestine, they will look for it and they will burn it. But if it's very, very extensive, I mean very extensive, that is involving major large intestines, what they will do is they will do a laparotomy. They will open you up, go there, assess it directly. If they can excise it, they will cut it out. But where it has affected a bigger part of it, they might excite the whole part of the bowel and reoppose the bowel back again. So it depends on the situation. They can go in, use the laparoscope to burn it, or they can go in and just excise that part of the endometriotic tissue out of it, and the person will be fine.
Okay, thank you so much for that explanation. I have a question in the chat. Are
Yeah.
there genetic causes for endometriosis?
Are there?
Genetic.
Yeah, so we are still looking into it. It's not so clear. Unlike uterine fibroid, that has been found to be very common among Blacks, endometriosis cut across every generation or every ethnicity. So we are not 100% sure whether there's a direct genetic input. What is really clear is the implantation theory. But in some few cases, they found out that what I was saying concerning what is it? Let me see if I can go back to that page. They found out that embryotic stem cells, like, let me give an example, like bladder and the ovaries, the bladder and the uterus, they stem out from the same embryonic stem cell. So they found that some of the tissue that were developed on the bladder did not necessarily come from implantation. It looks like it's just the bladder tissue that underwent some metastasis or changes, what we call the coulombic metaplasia theory, just underwent some changes and became endometriotic tissue. Those ones predict that there might be a genetic component, but we are not 100% sure what the pathway or the pathology looks like. So we can only say that these are the theory behind it, but we are not 100% sure there's genetics. But one thing we know is that if your family member have it, there's the likelihood that one of the generations can also have it.
Okay. Thank you very much.
What
other question, the next question was, why is it common among Black Africans? But it sounds like you, in your response to this question, it sounds like it is not specifically among Black Africans, but across multiple demographics.
Yeah, for endometriosis, it has been found out to be among multiple demographics. It's not specific among Blacks. The only thing I can say is that the intensity tends to be very higher among Blacks. It's still undergoing research for us to be 100% sure whether it has anything to do with Blacks, like the way uterine fibroids are strictly lineage of Black ancestry. We are not 100% sure of that of endometriosis.
Okay, thank you. Another question is, does nutrition influence endometriosis?
So I would say yes and I would say no. I would say yes in the sense that if it has been realized that those who are on healthy diets, even if they have endometriosis, their experience of endometriosis is very, very minimal compared to those who are on unhealthy diets. So that's why I said that the to-dos and don'ts. If someone is on alcohol abuse, is on fizzy drinks and all those things, a lot of fats, they tend to have a worse experience when they have endometriosis than people who are on healthy diets. So food plays a general role, but the direct role is still not being understood. So I will advise that if you don't have it, you eat healthily. If you have it, still eat healthily, because your experience might be minimal as compared to someone who is not eating healthily.
Thank you. Another question, is endometriosis just a gynecological issue?
So the foundation is a gynecological issue, and it will be treated by a gynecologist. But the complication can cut across many disciplines. So they've even realized that endometriotic tissue found in the nose, found in the lungs, there have been endometriotic tissues found even in the lungs, even in the liver. So whilst you are having your menses, someone is having a bleeding nose, just like having a menses. So during the period of having the menses, they will bleed from their nose. They will bleed from their nose. Another will be having bleeding in the lungs, such that it will require a specialist, lung specialist, to go in and help manage this kind of condition. So baseline is a gynecological condition, but it can go into different specialty because of how widespread these endometrial tissues can go.
Thank you. Another question. In the case of infertility, if someone has infertility due to endometriosis, can IVF be used as a remedy to the infertility?
Exactly, exactly. So if you have endometriosis, they will have to weigh the options available for you. So let's say you have endometriosis, and that's the reason why you have the tuber blockage. They will see if the tuber blockage is as a result of direct implantation of the endometriotic tissue, or as a result of adhesions that had blocked the endometriotic tissue. The easiest way is to go in, remove these adhesion bands, and see whether it will correct. But sometimes, after going through all this stress, it doesn't work. Then they will opt out for the IVF, because the IVF will bypass all these complications or all this process and introduce the fetus directly into the pathway where they will grow into the uterus and now become a healthy baby. So yeah, IVF is always an option on the table when you have endometriosis. Some endometriosis are so terrible that they can't do anything to bypass the uterine patency.
Can endometriosis cause pneumothorax?
Yes, yes. So that one is called non-pneumothorax. It's called hemothorax, not pneumo. Pneumo is air trapped in your lungs space, but hemothorax is blood trapped in your lung spaces. So because you are during your menses, you are bleeding, and those endometriotic tissue in your lungs is also bleeding. This blood is accumulated in what? Your lungs, and it's called a hemothorax. Yes, it can lead to a hemothorax.
Thank you. And I guess this might be our last question. What about bleeding from the gums during menstruation? Could that also be endometriosis?
It could be, it could be, but those one requires the common place we've known is in the nose. The common place we've known is in the nose, but not the gum. But yes, if you always bleed from your gum when you have your menses, just quickly go and see your specialist. It might have something to do with it. But just that during your menses, there are other nutrients that are affected. One common nutrient that is affected during your menses is vitamin D. And vitamin D can lead to what? Gum bleeding. So that's why I'm saying that I don't want to stick my head out and say the cause of it is from endometriosis, but it could be just because your vitamin D levels are so much down during your menstrual cycle, then your gums start bleeding. So that pathway is clear. It can easily be, and so the moment you go back to your vitamin D supplement, it stops. But if it is bleeding, like bleeding profusely, anytime you have your menses, then you have to see your doctor and let's examine what is causing it.
Thank you. Those are all the questions we have for today. Thank you so much, Dr. Osei, for your time and your
You're
expertise.
always welcome. You're
Yeah.
always welcome.
And we do plan. One last question. Uh,
Okay.
if it's removed, can it regrow the endometrium?
Yes, yes. The recurrency of endometriosis is really, really high.
Mhm.
So that's why we always have the combined therapy. So when they give you they even do the surgical interventions. They will give you some medication, so like the danazol or the, let me see if I can get it to the GNR analogs, where they put you on it for a period of time. Um, yeah, they put you on for about 3 to 6 months, the danazol for 3 to 6 months, so that the smaller ones that they could not identify and easily take them off can be killed or can be reduced by the medical drug.
Okay. Thank you very much. And again, thank you so much for your time and expertise.
You're always
Oh,
welcome. Always welcome.
and we are going to have another session in the near future.
In
Uh,
the near, like in the near, I think it's 2 months time from now. If we can confirm, I think it's in 2 months from now.
yes, we haven't
So we
set
can.
a date, but it will be coming up, and that one will be around perimenopause. Is that
That will be
correct?
on perimenopausal,
Yeah.
and I'm really excited to talk about perimenopausal symptoms because it's one of the things that we easily miss them, and it is really very detrimental because people go through it and they don't know how to handle it. So I will be happy to talk about so it's like premenopausal, menopausal, and postmenopausal symptoms. I'll be talking in wide extension from that period of time. Yeah.
Well, thank you so much, and thank you everybody for joining us today. And we hope to see you again at the next one. We'll send dates on when it occurs. Take
Okay.
care. Good rest of your Saturday, and go Team Ghana, Black Stars.
Yes.